وزدنا علما. I hope everybody is safe. This is the first time I give a virtual lecture. إن شاء الله المرات الجاية نكون رجعنا لطبيعتنا بإذن الله. Today I'm going to talk about ischemic optic neuropathy. Okay, just a minute. Okay, ischemic optic neuropathy. Ischemia is a disease, is decreased blood supply to the tissue of the optic nerve, which in turn decrease the oxygen and nutrition to the tissue. Tissue cannot function properly and will eventually die. So this is the idea of ischemia, which has happened. مو راضي يقلب السلايد. سامعيني؟
سامعين دكتورة تفضلي.
بس مش راضي يقلب السلايد, so I don't know what's happened. I'm trying to put the other slide, does not want to. Okay. So there is two clinical forms of ischemic optic neuropathy. It's anterior ischemic optic neuropathy and posterior ischemic optic neuropathy. All of you may be familiar with anterior ischemic optic neuropathy, and maybe you are not very familiar with posterior ischemic optic neuropathy. So let us talk now about posterior ischemic optic neuropathy. بيان ايش الخطوط اللي طلعت على الشاشة هذه؟ ما ادري من فين. Anyway, if you see here the optic nerve, there is anterior part of the optic nerve and posterior part of the optic nerve. The anterior part of the optic nerve is usually supplied by the lamina cribrosa, okay, which has come from the posterior ciliary artery, while the posterior part of the optic nerve is supplied by pale branch of the ophthalmic artery. So the posterior part now who is going to be affected. When we talk about posterior ischemic optic neuropathy, the posterior part is going to be affected. Posterior ischemic optic neuropathy is less common. It's usually secondary to ischemia of the posterior part of the optic nerve and usually happen bilaterally. So if it is affected, both eye affected at the same time. So let us have a scenario. Like here we have 60 years male complaining of sudden loss of vision in both eyes. This patient, they call you, he was just on the ICU, just wake up, status post coronary artery bypass surgery. And actually the physician will tell you that he was having hemorrhage and complicated by hemorrhage and hypotension. So you went to see the patient and you find that the patient really having hand movement vision in both eyes, and optic sign exists while you're looking to the fundus, optic disc looks normal. What does mean of optic sign exists? Optic sign exists that if you examine the patient before dilating drops, you will find that the pupil is not reactive. Optic sign mean that the vision is decreased and the color vision is decreased and patient does not see, but when you examine the eye, you find that the optic disc looks healthy. So this is what happened when the incidence is new, just fresh within the first couple of days. So here, when you examine the patient, the optic disc looks absolutely normal. So you cannot see anything in the fundus to tell you that he have any problem, but the patient does not see. And if you look to the optic nerve sign, it is exist. Well, you order MRI to see what's the problem. And here you can see here that there is enhancement of the optic nerve. And actually, this is the area which have low blood supply, hypoperfusion, and the optic nerve is affected. And in this area, you can see the area of the optic disc, which you see it, and you can see that you can see here the sheet of the optic nerve and normal optic nerve. And this is here again show you the enhancement of the optic nerve. So by this, you can be sure that this patient have posterior ischemic optic neuropathy. Now let us have another scenario. This is another patient. This patient is 40 years old, and she is well known to be hypertensive. This patient was having a very difficult day where she was very upset, very angry, and she had headache. So she decided to take more medication of her beta blockers before she sleeps, so that she does not have high blood pressure. The second day, she came to the ophthalmology. Again, she cannot see in both eyes except light perception. And you look to the optic disc and you find looks normal. So again, what's happening here? You know about posterior ischemic optic neuropathy. You examine the pupil before you believe the patient that she has something. So you went to MRI and she was having posterior ischemic optic neuropathy. Few weeks later, she came, and here what happened, that she started having pale disc in both eyes. So this is what happened in posterior ischemic optic neuropathy. When the incidents happen, when you look to the optic disc, it looks normal. But later on, in 2 weeks or 3 weeks, pallor of the disc start appearing. So we are dealing here with posterior ischemic optic neuropathy. Now, what happened to this patient? You know, it's nice to know that with blood pressure, normal blood pressure, this is the systolic blood pressure, and this is the diastolic blood pressure. So there is a normal variation during the day. And as you noticed here, from 10 p.m. until nearly 4 p.m., there is normal drop of the blood pressure. So the blood pressure slow down and go down normally during sleep. For the systolic and the diastolic, both drop. So when patient take more antihypertensive treatment at night, she took overdose, and we recommend usually not to be taking very soon after, like it's better to be taking before 8 o'clock. So here what's happened, the blood pressure dropped even more than normal, and that's why patient might have ischemic optic neuropathy. And usually when it is happen, it happen at night. So this is the cause. So posterior ischemic optic neuropathy, ischemia of the posterior part of the optic nerve supplied by minute pale vessels. It is very rare to happen, thank God. And if it's happened, it is usually bilateral. Now, what's the condition associated with posterior ischemic optic neuropathy? There is a lot of list of things which can be associated with ischemic optic neuropathy. But the most common is severe hypotension of the blood vessels or blood loss, It can happen after surgical procedures, especially if they have hypotension or severe anemia. And there, as you see, there is a lot of other causes, but these are the most common. So a posterior ischemic optic neuropathy is diagnosis of exclusion. So we have to exclude what is the cause. We cannot just say it is due to posterior ischemic optic neuropathy without doing MRI and be sure what is the cause. So let us go to anterior ischemic optic neuropathy, and this is the most common. So the most important part of anterior ischemic optic neuropathy is right, we are dealing with two different types, which is arthritic anterior ischemic optic neuropathy and non-arthritic anterior ischemic optic neuropathy. So these are the two type which we are going to talk about in these 2 minutes. Now, there is important key. The two key question is when you are having anterior ischemic optic neuropathy, it's very important to know and to ask yourself, is this anterior ischemic optic neuropathy or we are dealing with giant cell arteritis? This is very, very, very important. Why it is important? Because arthritic anterior ischemic optic neuropathy, or what we call it giant cell arteritis, is an idiopathic vasculitis which typically affect the elderly patient. It has a predication for large and medium-sized artery, particularly the superficial, temporal, ophthalmic, and posterior ciliary artery. The severity and the existence of involvement is associated with the quantity of elastic tissue in the median and adventitia of the artery. But still, why we have to differentiate? What is the importance of this? Arthritic anterior ischemic optic neuropathy is a true neuro-ophthalmic emergency. So everybody have to know how to diagnose arthritic anterior ischemic optic neuropathy, because you, the resident, are the first people to examine this patient in the emergency room. Probably they are calling the second on call or the consultant, and the way they are taking the history and the way will be systematic in thinking, that's what will save the patient eye. So why it is a neuro-ophthalmic emergency? Because blindness of the other eye can be prevented. So what we call it ophthalmic, neuro-ophthalmic emergency, if you are saving eye, vision, or saving life. So in here, you are saving the patient vision in the other eye, as well as you are helping in saving his life, because arthritic temporal arthritis can cause kidney failure, can cause heart failure, can cause organ failure as well. So, but we sometimes, ophthalmologists, sometimes are the first people to diagnose giant cell arteritis. So if untreated, bilateral involvement is common in 65 to 70% of cases. Is very high. Once one eye is affected, the second eye can become involved within days or weeks. So this is a very, very important to be able to pick up and know about arthritic anterior ischemic optic neuropathy. Now let us have a scenario. Now, here is a 65 years old male. He is known to be hypertensive and diabetic. He presents with acute loss of vision in his right eye. His vision, when he came straight forward, the second day, it's happened that he lost, he wake up in the morning and he noticed a decreased vision, so he ran to the ophthalmology emergency. You examine him and you find that he have acute painless loss of vision to counting finger in his right eye. His left eye vision was 20/20. You was very good, and you examine the pupil and you find that he have a relative afferent pupillary defect. You look to the fundus, it was swollen optic nerve in the right eye, and you did visual field, and he have a field defect. So here is the optic disc. What you noticed here different, that he have definitely disc edema. We are not in doubt about the disc have edema, but what else is specific about this disc? That the color, this is just happened yesterday or the same day. The color of the optic disc is milky white or yellowish white. Usually when we have any other papilledema, you see it, it looks pinkish in color, okay? But here is milky white. So this is a very important to be able to differentiate the way the color of the optic disc looks like in arthritic ischemic optic neuropathy. So here's the visual field. He have really decreased depression of vision, and the other eye looks normal. Now, here there's question you wanted to know about the patient. You have to ask him if he have headache, pain in the temple and or around the neck, pain while chewing, loss of appetite, loss of weight, unusual fatigue, muscle ache or pain, fever or night sweating. Why are you asking this? Because these are the symptoms of patient have systemic temporal arthritis. He might not have all, but he might have some of them. So this is something light up in each patient who is over 60. When you read in the American books, you find it over 70 or older, but in our society, actually over 60 years, when they present with sudden loss of vision, you have to ask for these symptoms to rule out systemic causes of temporal arthritis. Now what you will do? Now here is the patient who have some symptoms. You look to the disc. You suspect that he might have temporal arthritis. So what you want to do for him? So what's your plan? So you will do immediately ESR, blood test, ESR, C-reactive protein. Usually, whenever you draw a blood, it is better to do CBC and differential. Sometimes it surprises us with a landmark, whether he have severe anemia or any other causes. So what happened in this patient? When you done ESR, you find it very high. C-reactive protein was high. Of course, you have to know what's the normal of ESR for man and for woman. For woman, you double the age by 2 and you add 10, and this is the normal for the woman. And for the man, it's just the age times 2. So here you find ESR is high, C-reactive protein is high. Clinically, giant cell arthritis. So what you will do, start immediate treatment with steroid and arrange for temporal artery biopsy. So we are not wasting time to have the result of the temporal artery biopsy or to start the treatment after we do the temporal artery biopsy. So this is here urgent that we should start steroid. So temporal artery biopsy, you schedule temporal artery biopsy and you done a temporal artery biopsy. So what is the result? You find that it's positive temporal artery biopsy, like in here, and there is giant cell and there is inflammation in the elastic lamina. So we are all 100% with the diagnosis that this is a temporal arthritis, and we will start the treatment. Of course, we will seek the medical field, because usually patient is diabetic, hypertension, and we are going to use steroids. So we will have the help of medical team. So what about if we have negative temporal artery biopsy? What shall we do? If the clinical suspicious is high, like have a pale disc and he have sign and symptom of temporal arthritis, then you go for temporal artery biopsy in the other side. Why? Why I'm doing this? Because this patient usually is going to be for a long on steroid. And as you know, steroid is not of, is having complication. So you have to have a reason or a legal thing or evidence-based medicine for why you are going to put him on a steroid for a long time. Now, if it is negative, but there is not really sign and symptom of temporal arthritis, does not have any sign symptom, there is no temporal artery palpation on the side, there is no pain, there is nothing. So reconsider your diagnosis, although the possibility of temporal artery with negative temporal artery biopsy is considered. So we will depend on the experience and the clinical judgment and follow-up. And what happened, usually if it is negative, I follow him up like after 2 weeks or 3 weeks and look for the normal eye, look to the optic disc, because before infarction, with couple of week or 10 days, there will be start having edema without infarction. So I will put him back on steroid if I noticed any change in the optic disc. So here what we mean, considered, it will be considered, okay? Now, let us have this scenario, another scenario. This is elderly age patient, have severe sudden loss of vision. He complained of transient visual obscuration. You find swollen disc, milky color, no symptom of temporal arthritis. ESR-C reactive protein is normal on presentation. So what shall I do with this patient? You know, it's really confusing. He has sudden loss of vision, he is older, milky color disc. So why ESR-C reactive protein is normal? What's happening here? So here, what's light up? Older age, severe sudden loss of vision, visual obscuration, and milky color disc. All these make me think that I am suspicious. I am suspicious of this patient having temporal arthritis. I will be very, very careful. So what we are going to do with this patient? I will repeat ESR and C reactive protein 2 days to a week, repeat the T active protein, and I will do as well as fluorescein angiography. Why fluorescein angiography? Looking for sign of ischemia, because usually in patient with temporal arthritis, they might show As you see here, there is optic disc swelling as well as ischemia of the choroid. So if I find this, with this high suspicious, I will start steroid and order for temporal artery biopsy. This is unusual cases of temporal arthritis, but we have to know about that. Not everything is straightforward. So ESR might be normal in acute phase of temporal arthritis, where it can be normal. If the patient was having prior corticosteroid for any reason, like patient having chronic obstructive airway disease and he was giving steroid before, so we might have normal ESR. Impaired hepatic function, he have hepatic function that sometimes these can give us ESR normal, congested heart failure, or he have some blood disease like polycythemia or hemangiopathy. C-reactive protein is usually influenced by inflammation, might be high. So can be high if the patient, for example, diabetic and have gangrene or have infection. So any inflammation can cause high C-reactive protein. It influenced by tissue necrosis and is not affected by age or sex. So there is no different like an ESR between male and female. Now, perform unilateral temporal artery biopsy if it is negative. If positive, we have the result. If it is negative, if the temporal artery biopsy index of suspicion for giant cell arthritis is low, do not perform second temporal artery biopsy, okay? But if the pre-temporal artery biopsy index of suspicion of giant cell arthritis is high, then contralateral temporal artery biopsy to the other eye should be done. If it is moderate suspicious, individualized decision. So you will decide how you are going to manage this patient, and he will be in clear follow-up. Now, what's the treatment? How we are going to treat temporal arthritis? Usually we give 1 gram per 100 ml saline plus pulse dose of methylprednisolone once daily for 3 days, followed by 60 milligram oral steroid for 3 days, and then reduced to 40 milligram oral steroid for 4 days, and then we reduced prednisolone dose to 5 milligram weekly until 10 milligram is reached. And then he have maintenance dose of 10 milligram orally for maybe 12 months. And then we decided to stop it slowly and watch the patient, whether he will be stable or whether he will be on any other immunosuppressive medication, and that will be followed up between ophthalmology and medically. So here, why we are keen of doing or having documentation of positivity in the temporal artery biopsy, because the patient is going to be long on steroid. He might have complication of steroid. He already is diabetic. So we have to be sure like we are giving proper medication and taking the risk of steroid. Now, we go to the other part of the third part actually of our lecture, which is non-arthritic ischemic optic neuropathy. This is a dilemma. Why? What is non-arthritic ischemic optic neuropathy? It's low blood flow perfusion of the optic nerve head. Okay, let us see. So non-arthritic ischemic optic neuropathy is presumed to be a result of circulatory insufficiency within the optic nerve head, but the specific mechanism and location of vasculopathy remain unproven. So here, what we have, this is the camera, the electronic micro camera showing the blood vessels around the optic disc. And as we said here, it is with the optic nerve head pre-laminar and laminar and post-laminar are supplied by the short posterior ciliary artery, and there is as well as choroidal contribution in pre-lamellar and lamellar part of the optic disc. Why I said it is dilemma, because there is lot of causes of anterior ischemic optic neuropathy. The most common is hypertension, hypotension, diabetes, atherosclerosis, and hypercholesterolemia. This is the most common, but there is lot of uncommon causes, and especially when you have sometimes facing a patient who is young, 30 or 40, and he does not have diabetes, he does not have hypertension, he does not have any other causes, and then he have ischemic optic neuropathy. So we have to keep on looking and digging for the cause, and from here, that's why I'm saying it's dilemma. So let us just show you uncommon causes, like it can be Fabry disease, carotid occlusion, carotid artery, biopsy, acute blood loss, like post-surgery, after treatment of malignant hypertension, nocturnal hypertension, patient have, la samah Allah, cardiac arrest, and if patient is non-hypotension, here is important for ophthalmology. The known patient of hypotension or severe anemia, we have to be careful with this patient if we schedule for cataract surgery, LASIK, lower lid blepharoplasty, or any general anesthesia. So these are the people are at risk of having ischemic optic neuropathy. So we have to consider while we are evaluating the patient, especially the patient with severe anemia. Now, there is another ocular association, like a patient who is hyperopic, they are more at risk of having ischemic optic neuropathy. Patient who have optic disc drusen, papilledema, glaucoma. These are people have more susceptibility than normal people to have ischemic optic neuropathy. We called it disc at risk. Still, this is, we finished them. Infection, sometimes it happens with infection like herpes zoster, Lima, syphilis, AIDS, or in inflammation like Behçet disease and connective tissue disease. So there is lots and lots of causes of ischemic optic neuropathy, and this is why I said it is dilemma. So we have to find It can happen with leukemia, can happen with lupus, anticoagulation. So any non-arthritic ischemic optic neuropathy with a younger age, less than 40, with no systemic disease, especially diabetes and hypertension, we should really look and investigate for the cause. Some medication are well known to cause ischemic optic neuropathy, and we face it a lot, especially like Viagra, and sometimes it's happened with amidrone, with omeprazole for gastric ulcer, and others. So always we have to ask for medication. This is, I showed it before, is what happened with antihypertensive if taking very late at night or overdose. What is the doctor prescribed? Now, there is a strong association with anterior ischemic optic neuropathy and smoking. So a lot of articles have been written about the connection between smoking and non-arthritic ischemic optic neuropathy. So always I requested and to stop smoking, as it's really bad in any way. Now, people who have sleep apnea, these people are again have more tendency than normal population to have non-arthritic ischemic optic neuropathy. How we know sleep apnea? Usually they don't know themselves, but the partners might know, and usually they are choking a lot, they have loud snoring, suddenly they are awaking, restlessness of breathing, waking up in a sweating during night, feeling unrefreshed in the morning after night sleep. They have headache, sore throat, dry mouth in the morning. So not everybody having dry mouth or sore throat, he think that he have sleep apnea. They have a lot of daytime sleep, including falling asleep in appropriate times, suddenly, you know, like sleeping. So these people who might have sleep apnea. Now, disc at risk. Disc at risk, usually any patient who have disc edema, so they are susceptible to have non-arthritic ischemic optic neuropathy, even if it was pseudodisc edema, crowded disc, tilted disc, disc drosen, and if the patient was having previously papilledema. So this is what we call it, disc at risk. So let's have a scenario here. Like here we have 47 years old man, could be a woman or a man. Sudden painless decreased vision in one eye, color vision normal or minimally reduced. He have altitudinal field defect. He have afferent pupillary defect, disc edema. He have flame-shaped hemorrhage around the disc, and disc is not milky white, is pinkish here. So this patient was having risk factor. He is diabetic, he's hypertensive, he have atherosclerosis, smoker, or other. So this is like give you a little bit of risk factor. Another thing is really diagnostic. It's really diagnostic is when you look to the disc. Look to the disc here. You find that this part is normal and this part is odometous. So this is, if we see this, really, you know, like this is, it could be diagnosed non-arthritic ischemic optic neuropathy. If we look to the other disc, is small, crowded small disc. But here you can see this is segmental disc edema. And you can see the color here. The color is pinkish, you know, the color pink here, pink here. So it's pinkish, it's not milky white, like the other disc. When we did the fluorescein angiography here, you can see clearly here, you see like this part of the disc is normal and this part is having the disc edema. Okay, the other eye is normal. So this is non-arthritic ischemic optic neuropathy. So what we will do, usually we will do ESRC reactive protein because you have to keep it as habit to do it, to be sure that you are not missing anything. Fluorescein angiography to the optic disc, usually it shows delayed filling is very common. Temporal artery biopsy in suspected cases, not in this case, in suspected cases. MRI in atypical cases, like very young patient, sudden loss of vision. So I have to know and investigate and to know what's the other might be having other serious conditions. So now, what is the natural course? What's happened usually in these patients with non-arthritic anterior ischemic optic neuropathy? What happened to them? Natural course. It's usually unilateral, but over long time, 25 to 40% of cases have contralateral involvement, especially in disc at rest. So it's not like the other one, and 70 to 80% they might have other eye involvement. Here is lower, much lower. The chance of the second ischemic event in the same eye is very low. It's 3 to 4%. Usually does not happen. Very rare to have ischemic optic neuropathy in one eye, like he have here, half of his optic disc is affected, and to have another half is very rare. Usually they have it once. Now, what happened? Fixed visual field defect. We will have visual field defect, usually altitudinal field defect. He might have stepwise progression in the first 3 weeks. Up to 25% of patients might have a little bit of deterioration of vision, while 33% of patients, they might have some improvement of vision. So what I'm telling the patient usually, I'm telling them, I will do the visual field, examine them, do everything, and then I might tell them that let us wait for another 1 month. There might be some improvement. So I always like to give hope. And let us see. So natural course, we're still in the natural course. What happened in 6 months after ictus? Visual improvement, usually 3 lines in 43% of patients. So 43% of patients, they might have some improvement. Visual acuity worsen, 3 lines in 12% of the patients. So most of the patients might have a little bit of improvement. So I always tell them, let us wait, we might have some improvement, and we reassess visual field in 6 months, and usually minimal improvement, they will notice it a lot, so it make a difference for the patient, especially if it was near the central visual field. What is the suggested future should rise the suspicious of arthritic ischemic optic neuropathy? We keep on going to arthritic ischemic optic neuropathy because really we have to be sure what we are dealing with, because one, we cannot do, and we don't do anything, and another arthritic we have to do, and we have to save the other eye. So this is very important. So what are the things which you first saw that this diagnosis of non-arthritic ischemic optic neuropathy, and you might change your mind, or you have a suspicious, or you feel that this is dangerous? So if you have severe loss of vision, usually with non-arthritic, usually part of the vision is lost. He have altitudinal field defect. Part of the field, part of the vision is lost, but the other part, he sees through some area. While to have severe loss of vision of the whole visual field, to hand movement or light perception, this is suspicious. If you find that the optic disc color is chalky white, if you find that the cup disc ratio in unaffected eye is normal, so he does not have disc at risk characteristic of the optic nerve. If you done fluorescein angiography and you have choroidal non-perfusion, then you have great suspicious of changing your diagnosis to arthritic. Now, what is a suggested future should raise suspicion of alternative diagnosis? You are not dealing at all with non-arthritic ischemic optic neuropathy, and the sudden loss of vision is due to other causes. Like, for example, if you have malignant hypertension and you have here a lot of hemorrhage, exudate, and other thing in the optic disc, or like vascular disease, or you have uveitis, then reconsider your diagnosis. What is the cause of a loss of vision than non-arthritic ischemic optic neuropathy? If the patient have severe pain and severe headache, usually in non-arthritic ischemic optic neuropathy, there is no pain on ocular movement or headache. So in young, again, should have alternative diagnosis or REC for retrobulbar disease or optic neuritis or others. What is the medical? How we are going to treat this patient? Actually, until now, the only thing is available is to give patient aspirin, is 81 milligram once daily to be sure that the circulation is okay and the perfusion is okay. So this is one thing in our hand. A lot of study have been done in the past and still, like optic nerve sheath decompression, and it have been aborted because it was with worse prognosis, optic neurotomy, somebody came with doing some surgery and it was a failure. A lot of study done on an intravitreal bevacizumab and tissue necrosis, endothelial tissue necrosis, and they find really does not help much, like to give Lucentis and thing. Systemic steroids is of no place here. Only have been given with the ophthalmologist when they are in doubt whether they are dealing with temporal arthritis or non-arthritic ischemic optic neuropathy. Lot of ongoing studies still, but until now of really no result which have been proven. Still, a lot of research and lot of study going on. So until now, actually, no medical treatment to be given. But ophthalmologists should avoid telling the patient nothing could be done, as it's not helpful and it's not true. So how we are going to deal with this patient? What are going to tell the patient? What to tell this patient? Educate the patient about the nature, course of the disease. Educate him about the risk factor, medication taking without prescription, and refer them to medical care for controlling and treating associated medical condition like diabetes, hypertension, blood disease. In conclusion, Ischemic optic neuropathy, the major responsibility of ophthalmologists is to exclude giant cell arteritis. Arthritic anterior ischemic optic neuropathy is true neuro-ophthalmic emergency. Clinical judgment sometimes more important than just depending on lab results. Immediate evaluation and management is imperative in hope of preventing visual loss in the other eye. Posterior ischemic optic neuropathy is diagnosis of exclusion. Education of physician and public about arthritic anterior ischemic optic neuropathy and preventable risk factor. Preoperative identification of risk factor and prevention if possible. Disc at risk, anemia, hypotension, and etc. Patient might consider discontinuing exacerbation factor of nocturnal hypertension. Control of over-counter medication without prescription. Encourage smoking, decrease smoking or stopping smoking. Encourage more research study. And thank you. So,
يعطيك العافية دكتورة مها. It was a very informative lecture. Anyone have?
تفضلي. If anybody have any question.